Thanks very much. It's truly a pleasure and a privilege to be here. I'm going to speak to you about how we've managed innovation in the Peter Munk Cardiac Center, some of the examples of innovation that we've put into place, how those have worked out, what some of the things in the future are that are truly amazing, and how I think we could bring this process for enabling innovation to across the entire university health network. So, before beginning, I think it's important to understand exactly what innovation is. From the point of view of healthcare, innovation has to offer new benefits to patients, has to be valued by our patients, differentiates UHN from the competition, and improves healthcare delivery at UHN or creates economic value. Both would be innovative. There's a couple of types of innovation. Internal, that tends to be technology advancements, new treatments, and things that reduce cost, as opposed to external innovation, which tend to be new models of care, new marketing, new therapies, new devices, new patient experiences, but there's clearly an overlap between the two. You can also break innovation into two different types. First is incremental, evolution of an existing product or service. So that means making it smaller, better, faster. You have a stent, you make a bit smaller stent. You make a stent that works a little bit better. So that's one kind of innovation, and that usually happens internally. As opposed to breakthrough or moonshot innovation, where it's something that's completely new, radically different. Like I'll show you, rather than opening the chest to repair the aortic valve, making a little incision in the groin or no incision at all. That's usually external, and the balance between internal and external depends on what organizational focus has been established, and what drives that is the organization's appetite for risk, and I'll talk about that later. So, through constant innovation, the way that we treat cardiovascular disease is rapidly changing. The way we look at images of different structures, like the heart, is happening in ways previously not imagined. And I'm going to show you a video at the end of this presentation, so you have to stay for the whole thing. That's a first-in-the-world demonstration of holographic imaging from an actual patient. We use devices to treat heart disease that are getting smaller and require smaller incisions or no incisions at all, and I'll show you examples of that. We're going to be understanding how individual genes work so that we can personalize therapy for cardiovascular disease. This means having the resources to be able to take a biological sample from every patient, putting them into a biobank, and being able to analyze those genes. We'll also use stem cells increasingly to repair and regenerate damaged hearts, and I'll show you how we're doing that. So as we do all of this, it has to be done in an environment where there's fiscal responsibility and is safe. And all of that has to happen in a healthcare environment that's rapidly changing and evolving. So the question is, how does the PMCC, and indeed UHN, choose which innovative treatments to focus on? So to do this, we developed a couple of core principles. The first is we work in multidisciplinary teams. So here's a heart surgeon, RJ Cusimano, and a cardiologist, Eric Horlick, working together to put in an aortic valve through a minimally invasive approach. We use the best equipment in the world. This is the Fraser Elliott Multipurpose Operating Room, and I would say its big brother, the Trigger A, truly state-of-the-art intraoperative imaging facilities. And we've created a culture and established a clearly defined process that enables innovation through the Peter Munk Cardiac Center Innovation Committee. So what usually happens when somebody has a new device they want to try or a new procedure, they come to Bob or Justine or me and say, do you have any money, because we'd really like to try something new. Well, that's problematic. So we've moved towards a philanthropic-based approach with an innovation committee that I'll describe to you that makes decisions about what to fund. We get applications to fund devices or processes, and we have only one criteria for giving funding. The people we give the money to have to say they'll evaluate the device or the procedure, how it goes, and then submit the data to the Ontario Health Technology Assessment Committee. That's a group, 30 or 35 people, arm's length from the government, that basically says, yes or no, this works. If they say it works, the government is likely to fund it. And that's been our experience with funding for heart pumps, $2 million a year, blood vessel stents that I'll show you, $2.5 million a year, and aortic valves, which I'll also show you, a couple of million a year. And a few years ago, we had funding for none of those. So this committee, I'm indebted to its chair, Harry Rakowski. We thought that it would be appropriate for the committee to be half people from the healthcare world, because they have medical background, but could take a while making a decision, versus people in the business world who are more experienced at making decisions without all the information that you might like to have. And it's been a very interesting group, and I'm indebted to, I see Angela and Jeff in the audience and anybody else who's here for participating in this. So this was featured in the Globe last year as an innovative way to decide who gets funding for different elements in healthcare. So the first procedure that we funded was renal denervation, a surgical way to treat high blood pressure that affects 250,000 Canadians and is a leading cause of heart disease and stroke. This is a picture of the first renal denervation procedure done in the country. You see 3 physicians there. One is a vascular surgeon, one is a cardiologist, one is an interventional radiologist.
In health news, doctors in Toronto have become the first in Canada to immediately lower a patient's blood pressure without using any medication. They used an experimental surgery to get the result. Our health specialist, Jennifer Tryon, explains.
5 times a day for the last 5 years, Fatima Martin would check her husband's blood pressure.
I'm always scared that something is going to happen to him.
Medications, diet and exercise, nothing would lower his blood pressure.
Started with 1 pill and then 2 pills, and now I'm up to 6 pills a day and on blood pressure pills. It's still not controllable.
But this afternoon, for the first time in 5 years, Louis Martin's blood pressure is normal.
So everything went beautifully today.
He's the first in Canada to have his blood pressure lowered with no medication, no lifestyle change. Instead, doctors lowered it through a vein in his leg. Using a radio frequency probe, they severed the nerves near his kidneys, known for regulating cholesterol.
And it's been shown experimentally that if you interrupt those nerves, you lower blood pressure. You make a spiral going down the artery, so the idea is you're really trying to destroy those nerves permanently. Will that be the case? Time will tell.
Just hours after the procedure, Louis' blood pressure is reading normal. How long will it stay low?
That's one of the things that we have to study. The initial results are only for 6 months.
More than 250,000 Canadians have blood pressure problems. Medication can't help, leaving them at serious risk for heart attack and strokes.
Any innovative procedure needs to be borne out over time with further scientific evaluation, but it's a promising treatment for patients who really are just not well controlled with traditional therapies.
But the procedure isn't available for everyone just yet. Doctors here had to get special permission from Health Canada to do it. But if the results stay positive, which they have in a small number of clinical trials, doctors hope one day this treatment will be used to fight heart disease. For now, Louis and his wife are happy to be first and hopeful they've been given a new chance to beat a disease that claims more lives than any other. Jennifer Tryon, Global News, Toronto.
Second procedure that we funded was percutaneous, or through-the-skin repair of the aortic valve. This is Tyrone David doing an open repair of an aortic valve. That leaves a pretty big incision, and not everybody who has valve disease is able to tolerate this. So we thought that eliminating the need for an incision could decrease the morbidity of the procedure, and we wouldn't have to turn anybody away. This is a cartoon showing a stent graft, which is about 4 feet long, goes in through the right groin, up through the aorta, and into the chest. And that's R.J. Cusimano holding one of these valves to get an idea of exactly how big this is. So this is Teresia. She had a severely narrowed aortic valve and really couldn't walk. We took her to the operating room. This is another example of the multidisciplinary team. That's Pat Murphy in the orange, who is guiding an ultrasound probe to look at the valve through an ultrasound that's right behind the patient's heart during the procedure. So what you can see here, I'll try and show it on this one, is this over here is the stent graft. It hasn't been deployed yet, and when you inject blood, when you inject dye here, it refluxes back into the heart. It shouldn't do that. Second series shows the valve is partially deployed, but it's still attached, so you can pull on it and pull up and down to make sure it's in the right place. And this is really important because you may notice that we previously put some stents in the right coronary artery, and if the valve goes too high, you cover the stent and the patient would not do well. This is the third picture. That's the ultrasound probe, and you could see it moving. And now when you inject the dye here, the dye goes forward, and then you see it whipping down the aorta, and there's very little that goes back. And don't blink because you'll miss it. This is how long it takes for the valve to open. That's it. So you can imagine when that's happening, there's no blood flow for the patient to go through from out of the heart, so it takes about 3.5 or 4 seconds. And of course, I'm not going to show you a case that didn't turn out well, so this is Teresia a month later. Third place that we've gone to is stem cell therapy in the operating room. When people have a heart attack, that usually results from a blocked coronary artery. That leads to the death of some of the heart muscle, so the heart doesn't pump as well, and that leads to heart failure. The symptoms are low exercise tolerance, shortness of breath, decreased quality of life, and increased mortality. And this is the second leading cause of death in Canada. We think, as do others, that stem cells could regenerate heart muscle and actually cure patients with heart failure by regrowing new muscle.
We're taking you inside the operating room now for a rare look at an innovative surgery, only performed a handful of times in this country. Doctors are researching ways to repair a damaged heart, and they're doing it with the patient's own stem cells. Our health reporter, Kelly Crow, now, with the importance of this procedure. Kelly.
Peter, doctors here at Toronto General Hospital are pushing ahead with stem cell therapy, and earlier today we met one of the patients who's helping to lead the way. James Culross has become a walking experiment after doctors injected stem cells into his damaged heart.
I'm going to get better with the stem cells. Heart's going to get healed and that'll be it.
Culross had a serious heart attack in November, and his long-term prognosis was not good.
This is the most difficult population of patients to treat, and also the population of patients most in need of some new therapy, because most of our current therapies, medications, or for a very select few, heart transplantation or mechanical hearts, simply isn't adequate or isn't available.
So last week in this surgery, doctors tried something revolutionary. They took bone marrow out of Culross's hip, separated the stem cells on the spot, and then injected them into the damaged parts of his heart.
Probably in the next day, maybe 2, then we'll have you in good shape to go home from here.
Culross joins 9 other Canadians treated so far in one of the first clinical trials to put stem cells to the therapeutic test.
This is a very exciting development. We've been working on stem cell therapy for many years, and we're very pleased that now we have actually managed to bring this to the clinic.
It's the latest chapter in the long effort to move stem cells from theory to therapy. Early and controversial stem cell experiments used embryos, but scientists can now harvest stem cells from almost any adult tissue.
You know, it's your stem cells, nobody else's.
Which means his body will not reject them. The question now is, will the stem cells prompt his heart tissue to repair itself? So, you're kind of a pioneer here.
I'm a pioneer, a crazy Scotsman.
Expectations for this clinical trial are modest. Is it safe? And does it work better than existing therapies? Doctors are planning to try the technique on about 40 patients, both here in Toronto and in Montreal, and then they'll evaluate the results. Peter?
All right, Kelly, thank you. Kelly Crow in downtown Toronto tonight.
The other area that we're doing stem cell work in collaboration with the McEwen Center for Regenerative Medicine, is using stem cells as a patient. And this is how this works. You have a patient who has a specific disease, harvest their stem cells. We now have the ability to make those cells into heart muscle cells. You could then divvy up those cells and put them into 5 different dishes and try 5 different drugs and get an idea which drug was the one that would be effective to treat that patient in a dish before you ever expose the patient to the drug. So there's a couple of benefits there. You prevent patients from being exposed to drugs that aren't going to be effective, and then you have to say, well, this didn't work, so let's try something different. There's increased treatment efficiency, and there's also fewer drug-related side effects if you never have to see a drug that isn't going to be effective for you to begin with. So this is much better for patient care. Another area where stem cells will be tremendously effective is in screening for potential side effects. It turns out that one of the most common reasons for a drug to be withdrawn from the market after it's gone into general use is because there's cardiovascular side effects that weren't anticipated. The reason that happens is there's currently no really good way to tell, unless you give the drug to the patient, if there's a heart-related side effect. So if you took stem cells, made them into heart cells, and exposed the drugs to those cells, maybe you could tell if the drug wasn't going to be useful or if it had bad effects, and you could stop it from going down the hundreds of millions of dollar pathway that is required for drug development. So the drug companies will be interested in this, And of course, patients will be interested because they'll get the right drug the first time. So this is how we see this working. Same diagram as the first time. Take a patient with a specific disease, isolate the stem cells, take some heart cells, put them in a dish. Do the same thing with 3 other people with the same disease, or indeed with normal patients. Give them all the same drug and determine, is there any toxicity? And if you did that, you could prevent the drug at an early stage from going down this long road, which takes years and is very expensive, and that would increase the efficiency of drug development and would also be good for patient care. Also, if we're the place that develops these stem cell lines, we can license these lines to pharmaceutical companies, thereby creating revenue streams that would enable further innovation. Next thing that we funded was minimally invasive aneurysm repair. This is an abdominal aortic aneurysm where you see the bulge. If this ruptures, death in minutes to hours, and they don't cause any symptoms before they rupture. So the old way of doing this is long incision, long time in hospital, and if you can basically sew a pair of pants at the hem and stay calm with bleeding, you could do this too, although don't try it at home. This is a multidisciplinary team putting in an endovascular stent graft. On your right is KT Tan, the head of medical imaging, and on your left is Leonard J., a vascular surgeon, working together. This is before the surgery, and this is after the stent graft. So you don't see the bulge, all you see is the stent. And these are the incisions. You will notice that from here to here is 1 centimeter. So the incisions are less than 1 centimeter, and we think that the future is for people to have no incisions through the skin, come and go home the same day for aortic aneurysm surgery. Completely impossible to conceive of that 10 years ago. Last thing that I'll show you is personalized transfusion management during cardiac surgery. Dr. Kevan Karkudi, who's Deputy Head of Anesthesia, brought this to our attention. It's obvious that patients sometimes need to get blood during surgery, or platelets or plasma to help with clotting. He had a new way to measure if patients would be likely to need blood products during surgery. So rather than, oh, there's some bleeding, let's just give these products, they now do 2 tests. And this is the result of the trial. You see the frequency of requiring red blood cells during surgery dropped from 50 to less than 40%. Platelets dropped by more than 60%. That was fresh frozen plasma, platelets, and the need for very significant transfusion decreased as well. But importantly, equally importantly, I would say, the cost of the trial was $150,000 for 6 months, and the projected savings in blood products over a year just for heart surgery at this hospital is $1.5 million. So there's a clear return on the investment that the philanthropic community put into the Peter Munk Cardiac Center Innovation Fund to say, we spent $150,000, we saved $1.5 million. This program is being expanded across the hospital. So what's next in innovation? This is an MR PET. This is truly an amazing machine made by one company that allows you to assess both the structure of an organ and the function of an organ simultaneously. And I'm really indebted to Lillian and Norman Glowinski, Honey and Jeff Rubinstein, for making this possible. This is going to be the centerpiece of the MR PET radiopharmacy cyclotron facility, a $20 million installation that's going on in the basement of this building. And the beauty of this is some of the radioisotopes that the cyclotron makes, they only last a minute or 2. So with this system, an isotope could drop out of the cyclotron, be walked over to the patient, injected, and the patient scanned. So you have to have the foresight to build all of these things together in order to be able to do that. This is Ahmed Tawakkol. He's currently the lead of PET imaging at the Massachusetts General Hospital, Harvard Teaching Hospital, and I'm delighted to say formally for the first time, Ahmed has accepted the role as the Peter Munk Chair in Cardiac Imaging and will be the lead for the MR PET Center at TGH. So with everything else that's going on, how does UHN develop an innovation strategy to expand on what's happened in the Peter Munk Cardiac Center? Well, the strategy has to align with UHN's vision and strategic goals and has to be supported by the CEO. What's the vision? Well, clearly, we want to achieve global impact. Strategic roles, how will this support our vision? It has to be consistent with the strategic plan that Bob and senior management have put together. Core to this will be a new electronic medical record and a biobank so that we can develop genetic material on each and every patient and get into understanding why diseases happen so we can begin to focus more on prevention than on cure. Growth gap, this is going to be costly, so we have to consider this in terms of the current financial environment. And screening criteria, I think UHN is particularly good at this since we already have a balanced scorecard and we're used to measuring outcomes. So the second thing is you have to have a systematic and disciplined approach to enable an innovation process across an organization. It does not just happen. So we envision the creation of a UHN Innovation Strategy Team, and I'm telling you things now that don't exist. This has to be led by somebody who's dedicated. You can't ask somebody who's working 120% of capacity to take another 20% on and lead a process across the organization. And it has to be a multidisciplinary team that includes patients, government, possibly others. The second step is to explore problems and areas of need, but not every problem. You have to focus on the solutions that specifically address the healthcare issues that are important to the organization. And that's different than what we've done in the Heart Center, and it's a change that we might make. We didn't define what innovation is. We said, everybody come and tell us what you want to do, and we tried to pick the best quality. That's not the best approach because you're going to end up paying for things that are interesting but may not necessarily impact on a lot of patients. Third is to create a UHN-level innovation committee, and this is the process of expanding ideas. Once you've decided what you want to do, you assess the feasibility, the impact on resources, build the implementation strategy with the blocks that I described in the previous slide, start providing the therapy, and most importantly, see what happened. And this is the focusing the concepts aspect of it. Next thing is you need to establish a culture where you have cross-functional, multidisciplinary, diverse, and dedicated teams. People that aren't used to working with each other need to be thrown together because that's where you get ideas that are different than just the same old group of people getting together and talking about the same things. We need to promote a culture at UHN that encourages risk-taking and creative thinking. This is somewhat aligned with what Techna is currently doing. And this goes back to one of the first slides that I showed, establishing a balance between doing moonshot-type innovation, which is high risk, and incremental innovation, which is low risk, but you don't end up with anything that's brand new. We need to reward and celebrate success. This is not able to be financial in a healthcare environment like it might be in the business environment, but you can do things like celebrate your innovation, recognition events, grand rounds, dinners, give people access to senior management where they don't usually present at that level, and support training for leadership programs. And perhaps most importantly, we have to be accepting of failure. Obviously, you can't fail all the time, but if you're going to do more high-risk interventions, more high-risk things, you have to accept that some of them are going to fail so that you can get the others that are the absolute winners. So, the future of innovation at UHN, we believe that today's innovation is tomorrow's practice. There is no question that philanthropy is the cornerstone of medical innovation in Canada. Without the support of the philanthropic community, there's no Peter Munk Cardiac Center Innovation Committee, and none of those procedures that I showed you would have been possible, at least not here. We believe that we're a worldwide leader in the introduction and assessment of innovative technologies and approaches to the management of cardiovascular disease, and think that the approach that we've used can be expanded on and improved and implemented across UHN. Can't end this without thanking Linda Goldsack and Jeff Rubinstein, who are the leads for the PMCC fundraising campaign. Thank you, Jeff and Linda. And acknowledge the contributions of Louise and Tennis, who run clearly the best foundation in the world. I appreciate your attention and be happy to answer any questions.
Barry, listen, on behalf of the foundation, but most importantly on behalf of our patients, thank you for your leadership in demonstrating how philanthropy simply turns into innovation. Thank you so much for this talk today.